Assalamu alaikum. Thank you for this invitation. I'm happy to be part of this team to present today.
Can you
I'll
come
be
closer to the mic, please?
Yeah, sure. I'll be presenting Hep B treatment decision in a special population. Hep B virus management requires specialized consideration for certain patient population. I'll be focusing on the newest guidelines that was published, the updated guidelines in 2025 in November. The target population, pregnant women and women of childbearing age, patient on immunosuppressive therapy and risk of reactivation, co-infection with HIV and Delta virus. The treatment goal is to prevent the risk of transmission from mother to child and the progression of the disease to cirrhosis and HCC. And doing this ideally by achieving undetectable viral load and normalized ALT. The ACLD recommends screening all pregnant women for Hep B surface antigen at the first prenatal visit of each pregnancy, regardless of the vaccination status or previous testing history. The rationale is early identification allow for timely antiviral prophylaxis and therefore reducing the risk of transmission to the baby. The 2025 updated guidelines suggest initiate antiviral therapy at gestational week 28 if viral load more than 200,000. Earlier treatment at week 16 may be considered in high-risk pregnancy and potential preterm delivery. The goal is to suppress the maternal viremia and reduce the risk of perinatal transmission. And we should always coordinate the care with the neonatal team for timely vaccination and immunoglobulin. The preferred treatments, TDF, first line, most extensive safety data in pregnancy and long-term follow-up of infant, cost-effective and widely available. Other alternative is staph, safe and effective alternative, better renal and bone safety profile, less long-term safety comparing to TDF. Postpartum management, it depends on the indication for treatment. If we are giving the treatment to reduce the mother-to-child transmission, then the treatment should be given for 12 weeks postpartum, and we should continue monitoring the patient with the viral load and ALT for at least 6 months postpartum. If the treatment for, if we're giving the antiviral for the cirrhosis or active Hep B, then patient should be on antiviral therapy indefinitely and to follow the standard management. Infant care, Hep B vaccine and immunoglobulin should be given within 12 hours, and completion of the second and the third Hep B vaccine doses before 6 months. If Hep B immunoglobulin is unavailable, then the ACLD new guidelines suggest starting treatment at gestational week 16. Combined with infant vaccination alone, the study showed non-inferiority to Hep B immunoglobulin strategy. Breastfeeding is considered safe with staph, with the TDF, and we should test the baby at 9 and 12 months. With the Hep B surface antigen to rule out infection and with the Hep B surface antibody to check immunity. What about women of childbearing age? Hep B surface antigen positive women planning to become pregnant in near future, especially if over the age of 30 and viral load more than 200,000, may be considered for immediate treatment rather than waiting for future pregnancy. In Hep B reactivation, all patients planned for immunosuppressive therapy should be tested for Hep B surface antigen and core antibody. Patients who are Hep B surface antigen positive have a significant higher risk compared to surface antigen negative or core positive. Who is at the highest risk? All Hep B surface antigen positive patients are considered high risk, regardless of the baseline viral load, especially if they're going to receive B-cell depleting agents such as rituximab, hematopoietic stem cells or solid organ transplant, high dose of steroid, anthracycline or anti-TNF. All Hep B surface antigen positive should receive prophylactic antiviral therapy before starting immunosuppressive therapy, 7 to 14 days prior to treatment, and they should continue on treatment for at least 6 to 12 months after cessation. And if the patient is going to get rituximab or stem cell transplant, then they should continue for at least 18 months. What about the Hep B surface antigen negative, core positive, resolved infection or past infection? This group has a lower but still clinically important risk of Hep B reactivation depending on the type of immunotherapy. According to the ACLD, management is risk-based, not universal prophylaxis. So the high-risk regimen include B-cell depleting agent, hematopoietic stem cell transplant, high-dose steroid. These patients should receive a prophylaxis prior to starting treatment and continue for 12 to 18 months after cessation. Moderate regimen such as anti-TNF, adalimumab, ustekinumab, anthracycline derivative should either receive a prophylaxis or monitoring. If monitoring reliability is doubtful, if we believe that the patient will not gonna come to do a routine monitor, then it's safer to start the antiviral therapy. Low risk regimen such as antimetabolites or short duration of oral steroid, then in this patient you can safely continue to monitor them. Post-cessation monitoring, we should monitor these patients with viral load and ALT for at least 12 months. And if there is any flare in viral load or ALT, we should immediately restart treatment. Additional measure, vaccinate all non-immune patients and their household and sexual contact. Counseling patients to prevent potential fatal reactivation is very important. Co-infection with HIV, the updated guidelines suggest all people living with HIV should be screened for Hep B infection, and if they're not immune, we should vaccinate them. All HIV co-infected patients require treatment regardless of the CD4 count or the Hep B viral load. And patients who have interruption in HIV therapy that include any Hep B active antiviral therapy should be monitored closely for reactivation. The HCC surveillance, men with HIV, they should have semi-annual ultrasound with alpha-fetoprotein starting from the age of 18, and for women starting from the age of 40. Co-infection with Delta, all Hep B surface antigen positive co-infected with the Delta virus should receive treatment regardless of the viral load or degree of fibrosis. Interferon for 48 weeks should be considered in individual without a contraindication. Bulevirtide should be prioritized for the co-infected patients who have advanced liver fibrosis. The HCC surveillance semi-annual screening for adult with Hep B and co-infected Delta, regardless of cirrhosis status. This strength is conditional. The rationale is because of the annual HCC incident rate is 1.87%, even without cirrhosis. Case. A 24-year-old woman from an Hep B endemic region comes for a routine health check. She feels well, denies any symptoms. Her past history revealed that her mother is a known Hep B carrier and she was never vaccinated after birth. Her blood work showed Hep B surface antigen positive, A antigen positive, viral load 8 log, ALT normal, ultrasound normal. She is diagnosed with a chronic Hep B infection in the immune tolerant phase. Should individual in the immune tolerance phase start antiviral therapy versus observation? The updated guidelines suggest antiviral therapy for those over the age of 40 with significant liver inflammation, grade 2 or higher, fibrosis F2 or greater, on liver biopsy or non-invasive test. Person under the age of 40 who are interested in starting treatment earlier, the ACLD suggests shared decision-making with consideration of the risk factor as well as the benefit and risk of treatment. Factors to guide decision-making should include age, child versus adult, family history of HCC, and likelihood of adherence to treatment and monitoring, and prevention of transmission to others. Second case. A 42-year-old man is referred to hepatology clinic after incidental discovery of hepatitis B during a routine pre-employment screening. He was born in Hep B endemic area and report no history of acute hepatitis, blood transfusion, or high-risk behavior. He does not drink alcohol and has no significant past medical history. He is asymptomatic. Physical examination was unremarkable, with no stigmata of chronic liver disease, and his BMI is normal. His blood work showed positive Hep B surface antigen, E antigen negative, viral load fluctuating between 1500 to 2500 on repeated testing. His ALT intermittently elevated, ranging from 30 to 50, and bilirubin, INR, and albumin were normal. Imaging, ultrasound was normal. Fibroscan showed F0, F1. Clinical interpretation. This patient does not fit neatly into classical chronic Hep B. His viral load is not persistently low enough for inactive Hep B. ALT is not persistently normal, but not consistently high either. No clear biochemical or virological pattern of immune active hepatitis. He is therefore classified as Hep B E antigen negative chronic Hep B virus infection in the indeterminate phase. The indeterminate phase is defined as Hep B surface antigen positive, E antigen likely negative, without cirrhosis, do not clearly meet the criteria for either inactive or active Hep B hepatitis based on the ALT and viral load. Risk stratification should guide our decision. Patients with higher risk features are more likely to benefit from treatment. Older age, more than 40, evidence of significant fibrosis, more than F2, family history of HCC, high normal or fluctuating viral load near active hepatitis, other risks such as male sex or metabolic liver disease. The ACLD suggests antiviral therapy using a shared decision-making approach by assessing risk and benefit and to reevaluate that decision at each follow-up visit if treatment has not been initiated. Last but not least, treatment withdrawal. The guidelines overall stance is very conservative about stopping nucleotide analog therapy in most patients, unless a true functional cure, Hep B surface antigen loss, has been achieved. Those who may consider stopping treatment should meet all the following criteria: no cirrhosis, no history of decompensation, no HCC, no co-infection, undetectable viral load for at least 2 years, Hep B antigen seroconversion, low quantitative Hep B surface antibody, reliable patient for intensive follow-up. Summary. The 2025 guidelines represent a paradigm shift toward earlier, broader treatment with enhanced surveillance. The goals of antiviral treatment are prevention of progression to cirrhosis, development of HCC, and liver-related death. Other goals of antiviral therapy include reduction in onward transmission, both vertical and horizontal. Shared decision-making is a collaborative process where a healthcare provider and patient make informed decision to achieve the WHO 2030 elimination goal. Thank you.